So it's my pleasure to introduce our Grand Round speaker for the day. As many of you know, Jack Lin is one of our second-year fellows. Jack got his undergraduate degree from UC Davis in neurology, physiology, and behavior. That's an interesting combo. I like that. Before coming a little closer to Milwaukee and Des Moines, where he finished his medical training and his residency, and had a short stint as a hospitalist before joining us as a fellow. It's been our pleasure to have him so far. And he's presented multiple posters at national meetings, several thyroid posters at ACE and Endocrine Society, but he has a particular interest in obesity. And today he's going to be giving his talk, From Habits to Health, Navigating Lifestyle Modifications. Jack, it's all yours.
Thanks. I have no financial disclosures. So the objectives of this talk are to appreciate health impacts of physical activity, health impacts of dietary patterns, and understand strategies to assist patients in behavioral modifications to improve adherence to lifestyle changes. So I'd like to start just with physical activity. I think this is an interesting MRI. It's from a physical therapy journal, but this is the MRI of a 74-year-old man's quadriceps. You can see the adipose tissue is the white on the outside, and the center is the actual quadricep. When you compare it to this image, this one's of a 40-year-old man who also is a triathlete, and you can see there's significant more quadricep, a lot less adipose tissue. On the other hand, when we look at this image on the right, the one on the left and right, at least from my non-radiology eyes, they look pretty similar. And the interesting thing about these pictures is that the one on the right and the center, they're the same age. The difference is just the one on the right is a triathlete and the one in the center is a sedentary man. And I think this series of pictures is really nice to just illustrate visually for anyone that, the importance of physical activity and what that can mean. So when we look at physical activity trends, though, this is a graph from physical activity guidelines for Americans. And the blue is the women, and the orange is the men. And basically, men are maybe a little bit north of 20%, and women are a little bit south. But roughly, you can see that maybe 1 in 5 people are meeting physical activity recommendations. And that's what this graph is trying to show, that when we look at 18 people who are 18 or older, how many of them are actually meeting those aerobic and muscle training guidelines? So it's about 1 in 5 Americans are. And those guidelines are, just hitting 150 minutes of moderate intensity physical activity per week, or 75 minutes of vigorous intensity activity per week, as well as at least 2 strength training sessions per week. And the benefits of that are a lot, innumerable, but here I'm talking mostly about just these 3 components, which are the benefits it has to cardiovascular health, its ability to maintain and build lean muscle tissue as well as bone tissue, and its contribution to energy expenditure, though it's a little bit more modest. So when we look at aerobic activity, it can be measured in METs. And for me, I always like ascribing numbers to things. And I never really knew what METs was in internal medicine. And it was something I learned basically preparing for this talk. But 1 MET is the amount of energy expended in a minute when you're at rest. 2 METs is standing, 4 METs is walking 4 miles per hour, which is about the speed that most people transition from walking to a light jog. And then 16 METs is actually running about 10 miles per hour. And you can see the spread of things here, where light to vigorous activity, and on more vigorous, you have things like jogging or shoveling, and then more light activities such as walking slowly. But this, I think I like just because it helps conceptualize how vigorous should we be exercising when we're talking about moderate intensity or vigorous activity. This is a trial from 2018 in Australia. And there's actually 2 of these trials. This one's called Lift More, and it's from 2018. There's another one called Lift More M, and it's from 2020. They were trying to evaluate the effects of resistance training on bone mineral density and overall physical function. This trial is focused on postmenopausal women over 50 who had at least had osteopenia with a t-score of -1.0, and LIFT-MORE-M was focused on men. In regards to this trial, which is the one I'm talking about, you can see that when we look at the t-score for these patients, at least -2.1, I mean on average -2.1. So these patients, for the most part, had osteopenia and some even osteoporosis, or at least elevated fracs, given a good portion of them were also on therapy for osteopenia/osteoporosis. Exclusion criteria for this study were, for the most part, they were just trying to exclude patients who couldn't do physical activity or had medical issues that would interfere with bone density, such as even diabetes or severe cardiovascular disease. And they also wanted to make sure medications that could affect bone density were not being used by patients, such as glucocorticoids. So for the most part, this population is a group that has at least osteopenia, but is otherwise pretty healthy. So what did they do for these patients? Well, the study lasted about 8 months, and there were two groups. They had the intervention and the control group. The intervention group met twice weekly for 30-minute training sessions, and they did this under the supervision of a physical therapist in a training center. Then the control group was twice weekly, 30-minute training sessions at home. When it comes to the intervention group, they performed compound exercises: deadlift, overhead press, back squat, jumping chin-ups with drop landings. And they did this at a volume of 5 sets of 5 repetitions with 80 to 85% of that 1 rep maximum as the intensity. And what that translates to basically is every lift that someone does, they have a 1 rep maximum for that particular lift that they're able to perform. Most athletes don't train 1 rep maximums outside of like Olympic weightlifters or powerlifters or strongmen, just because lifting to that intensity it can increase risk of injury. So doing 80 to 85% is pretty intense, I would say, for most people who lift weights. If you compare that to the other group, these patients had a 10-minute walk at the beginning and 5-minute walk at the end. They then did lunges, calf raises, stand forward raises, shrugs, stretches, which included side-side neck, static calf stretch, shoulder stretches, and side-side lumbar spine stretches. These exercises, they note that were specifically designed to help promote and retain bone density. And they did it at an intensity of 10 to 15 repetitions, and it was less than 60% of that 1 rep maximum. And they, for the most part, did body weight up until the very end, where they did graduate to using about 3 kilogram hand weights. So, okay, it's bigger here, good. So here you can see kind of the results of this study. So if we look at the top graph, which is the table 3 to start, and we look at the far right, you can see that these were statistically significant outcomes with those p-values. And we can actually see the bone mineral density when you look at the control group, maybe not surprisingly, went down by on average -1.2% for the lumbar spine, -2% for the femoral neck. So maybe not surprising given the fact that as we age, bone mineral density will go down. On the other hand, when we look at the high intensity group, they actually had an average increase in bone mineral density, 2.9% plus or minus 3.1. So some patients did lose, but on average, there's a 2.9% increase. Similarly, you can see for the femoral neck, it's like a 0.3 increase, is a much wider spread, but on average, patients gained bone mineral density during this time frame. So that kind of is really interesting to see that high intensity exercises actually increased bone mineral density on average in this patient population that already had osteopenia or even osteoporosis. When we look at table 5, this table is trying to measure the actual functional performance of these patients before and after the intervention. And if we look at that far right, again, statistically significant difference. And you can just do an eyeball test. If you look at, for example, leg extensor strength, they went from 5.1% when the control group changed versus 37% increase when you look at the high intensity group. And that kind of just shows the functional performance improvement in these patients, which hopefully would translate to decreased risk of falling overall. Now, a couple of things to consider with this study is that, first of all, what adverse events occurred with this? Well, there was one patient in the high intensity group that did have lumbar spasms during her training, but she had to take she missed a couple sessions, but then she was able to continue and complete the entire 8-month course. Otherwise, there were no fractures or other major adverse events that these researchers reported. And the other consideration, of course, is the fact that they were very supervised. They were in a setting with a physical therapist, monitoring them and making sure that all of their exercises were done correctly. I want to transition a little bit and talk about energy expenditure. So when to review a little bit, when we talk about energy expenditure, there are really 4 components that you can break that down into. There's obviously resting energy expenditure, which is the energy that someone burns when they're just kind of at rest. There's non-exercise activity thermogenesis, which is the energy you burn when kind of going through your everyday activities. Exercise obviously has a certain amount of energy that is expended with it. And there's thermogenic effect of food, which is the amount of energy required to process food and liberate it in order to turn it into calories and energy you can use. When we look at energy weight in response to exercise, it doesn't really do great. This is a study from 2003, and it looks at 202 patients who were randomized to low moderate physical activity with standard behavioral therapy compared to high moderate physical activity with standard behavioral therapy. And you can appreciate at about 6 months, the amount of weight loss between these two groups was pretty comparable. But it's kind of after that fact, you begin to see the bifurcation of these lines, really demonstrating that exercise, while it might not help patients achieve that weight loss, it is beneficial and important when it comes to maintaining the weight loss that they've gotten to that point. This is a study from 2024. It's a series of 2 studies. One is from 21 and one is from 24. These studies were trying to look at how patients respond to liraglutide, 3 milligrams, when it's given in isolation, or when it's compared to exercise alone, or when it's compared to exercise with that liraglutide. There were 195 patients, and for the most part, they didn't have serious chronic medical conditions, including diabetes. They had obesity, and the BMI was about 32 to 43. The study design started with an 8-week low-calorie period where, on average, patients lost about 13 to 14 kilograms. Then there was a 52-week intervention period where patients were randomized 1-to-1 to 1-to-1 to placebo, which was no intervention and no exercise level changes, no physical activity level changes, followed by another group which was just exercise, a third group which was just liraglutide, 3 milligrams, and a fourth group which was exercise plus the 3 milligrams of liraglutide. After that 52-week intervention period, there was no contact between researchers and the participants for 1 year, 52 weeks. And then at 104 weeks from the onset of this study, patients were recontacted and kind of measurements were retaken and evaluated. So what did we kind of see from this? So unsurprisingly, when we look at that gray line, that's the placebo group. Patients without exercise changes or medication, they regained weight during treatment as well as post-treatment phase. When we look at exercise, which is the green line, again, this reinforces what we learned earlier, which is, these patients' weight gain was attenuated with that exercise. And afterwards, during the post-treatment phase, there was regain that was more rapid than during the treatment phase as well. I would like to point out, though, that when you compare the exercise group to the liraglutide group alone, the slope of those lines is pretty different in that the exercise group, likely some of them were continuing to exercise, and they curbed some of that weight loss during that time frame. The other interesting thing to point out with this exercise group is when we look at this next graph, which is how did their body compositions change during this time frame? So when we look at that treatment phase, you can see on the far left, that first graph on the left looks at the body fat percentage change. And And you can see that that body fat percentage these patients lost was pretty comparable, if not basically the same as the liraglutide group. On the other hand, if you look at the far right, that's the change in lean mass these patients had. And again, that green line is significantly above that blue line, kind of showing that, yes, the exercise patients, they didn't lose weight necessarily during this time frame, but they were causing a body recomposition for themselves. They were losing fat and gaining muscle or bone mass. So that in itself is important and beneficial. When we look back on this graph and we look at the exercise plus liraglutide group, yes, exercise alone is not going to necessarily help a patient lose weight, but the combination of that with medication, at least in this study, shows a magnification of that effect. And you can see even more weight loss occurred with these patients. How did that affect their body composition? Again, you can see increased fat loss with these patients compared to the liraglutide group alone. And then again, some of these patients actually had some lean tissue gain during that intervention phase. And again, if we compare the lines in exercise plus liraglutide group, which again, in that post-treatment phase, these patients were not getting liraglutide. And we compare to just the liraglutide group alone, the rate of weight regain that occurred in that post-treatment phase was significantly lower than the liraglutide group alone. So all this together kind of shows that, again, exercise is not necessarily going to help with the weight loss, but it can cause body recomposition, which is important and beneficial. And when we combine it with medication, we can magnify that effect that we're hoping to achieve for patients when it comes to their weight loss goals. This is the All of Us research program. It's from 2022. Basically, researchers took about 6,000 patients, which is a little bit of a skewed group. It's 73% female, 84% Caucasian, 71% college educated. The average age was 57, the BMI was 28. But they took these patients and they measured their step counts via Fitbits. And then they tried to evaluate their risk of developing multiple comorbidities. Here we have diabetes, hypertension, GERD, depression, obesity, and sleep apnea. And what they found was that when we look at these graphs, you have the x-axis, which is the steps they're taking. The y-axis, you have the hazard ratios for these various comorbidities. You can see that there's an inverse linear relationship that begins to occur with all these problems except for diabetes and hypertension, where there's a plateau effect that seems to occur on 8,000 to 9,000 steps. So something that's helpful to keep in mind when we're counseling patients on physical activity in general, even something such as ambulation will help with risk of developing other issues. And you can kind of expect some benefit for hypertension and diabetes up until even like 8,000 to 9,000 steps per day. I'd like to finish this section just by looking at this observational study from 2001 in preventive medicine. So this study was from the UK. They looked at people who are going up and down, people who are going up a flight of stairs or escalators. Now they were in a mall and there was a flight of stairs next to escalators, and they looked at who chose to pick escalator versus stairs, and they differentiated people based on male and female, as well as who appeared over 60, as well as under 60. And you can see at the bottom left, that's the baseline evaluation. That bottom left square box, that is women over 60, where coming in just shy of 5%. And you can see the triangle dash line at the far left, that's men under 60, coming in just north of 10%. So at baseline, these patients, these people were picking these people were primarily picking escalator instead of stairs when unprompted. About 5 to maybe 10% of people were actually picking the stairs when unprompted. The researchers then put up banners, kind of encouraging people to pick stairs over escalators, and you can see there is a benefit to that. That encouragement kind of helped motivate people to pick stairs instead of escalators, and that benefit remained even afterwards in that follow-up period, 14 weeks out. Those patients, those banners were removed, but still some people were picking stairs over escalators at that point too. So this kind of just shows the benefit of encouraging people to do physical activity, even if that like for some reason there's interruption there, that benefit seems to still stay. But it also shows what we talked about at the very beginning, which is at baseline, people don't really want to do physical activity. I want to transition a little bit to diet. I think this graph is really interesting. It's from Diet Collaborators in Lancet, a 2017 study that looks at the health effects of dietary risks in 195 countries. So if we look at the far right, you can see the number of deaths in a global level attributable to diet. And in the far left, you can see the mortality rate attributed to that. The left side breaks things down by SDI, which is Socio-Development Index, which is how economically developed a country is. On the far right, it breaks things down based on the mortality. You can see cardiovascular, type 2 diabetes, neoplasm, other causes, and you can see, of course, the primary thing contributor to mortality is cardiovascular disease. When we look at the diet components that we can attribute to these issues, the top 5 are high sodium diets, low whole grain diets, low fruit diets, low nuts and seed diets. I mean, diets that are low in nuts and seeds, and diets low in vegetables. So those are kind of the top 5 things that we can see that are contributing to mortality overall for patients. When we look at 3 and 5, which is diets low in fruit, diets low in vegetables, there's actual studies that kind of look at how much should you actually be eating in a day. And this is a really interesting one from 2014, the British Medical Journal. So they plotted out fruit and vegetable consumption in servings per day and looked at the hazard ratios of all-cause mortality. And you can see that, again, an inverse linear relationship play out as you consume more fruits and vegetables up until a point about 4 servings. So that kind of, at least when I talk to patients, I always promote these things up until I'm trying to get them to 4 servings, because then I know that's where that mortality, that bulk of that benefit is coming. And I tell them, at least try to get 4. And I tell them about this, just so that everyone can try to get to that much, and then we can maybe work on other things. I want to talk a little bit about dietary patterns. Full disclosure, there are a lot of different dietary patterns people follow. I'm going to talk about 4 that are due to their popularity at this current time or the research behind them, but there are a lot of different ones that have kind of come and gone. The first one I'm talking about is the ketogenic diet. So this is a diet that originally proposed in 1921 by 2 separate people, 2 separate researchers, Wilder and Woodhead. They proposed this diet, and it was initially used for kids with epileptic seizures. And it was used pretty frequently up until about the 1970s to early 2000s. Due to the advent of anti-epileptic meds, it became less popular. But then it kind of entered the cultural zeitgeist in the early 2000s, just because it was used on a kid named Charlie, who was 2 years old and was being treated for epileptic seizures at Johns Hopkins. And the news kind of made a piece about it. That's kind of how it re-entered our cultural vocabulary. So what exactly is the ketogenic diet? Well, when it comes to its use in weight loss, this is kind of a common structure that people follow. So the induction phase starts with 20 grams of carbs per day, no starchy vegetables, and it encourages leafy greens, adequate protein, higher portions of fat in order to reduce insulin and generate a state of ketosis. It is then followed by ongoing weight reduction phase, which allows for a wider variety of vegetables, seeds, and nuts, and lower glycemic fruit. And then the pre-maintenance phase occurs after weight loss is achieved. Carbohydrates are slowly reintroduced so long as weight gain doesn't occur. And the maintenance phase, patients are typically consuming 60 to 90 grams of carbohydrates as long as weight allows. And it's primarily recommended to be from legumes, whole grains, fruits, and those types of things. Ketogenic diet considerations, all phases encourage a balance of saturated, monounsaturated, polyunsaturated fats. All phases discourage ultra-processed and refined foods. Foods high in glycemic index are low, and foods rich in trans fatty acids. All phases except maintenance phase discourage consumption of cereal, bread, grains, starchy veggies, and roast food. So major pros and cons of this diet. it can help with weight loss. It may reduce hunger. It can lower carb intake and thus reduce insulin needs in patients. And it may lower diastolic blood pressure. It can increase LDL. I'll talk more about that next. Its effect on physical exercise performance is inconsistent. Patients who transition into running on ketosis sometimes note some increased fatigue as well as decreased mental acuity. And it's unclear the long-term helpfulness of staying in prolonged ketosis. So this is a case series from NYU. And it's titled, and I thought it worked great, so I left it there, Ketogenic Diet, Not for Everyone. And it's a case series of 5 patients who went onto the ketogenic diet. So I highlighted 3 patients here because these 3 were primarily affected just by diet. So patient 2, her LDL was 563 while on the ketogenic diet. They recommended medication as well as lifestyle changes. She refused and just did lifestyle changes. Her LDL went down to 143. Similar story with patient 3, where started at 243 and went down to 105 with lifestyle changes and with changing their diet from a ketogenic diet. And patient 4 actually is the other way around. Their LDL prior to a ketogenic diet was 142. They started a ketogenic diet, their LDL went up to 553. Patient 1 and 5, patient 1 also was started on statins, fibrates, and got bariatric surgery. So, but their LDL went from 683 to 65, triglyceride from 1109 to 158. And patient 5 was started on medication 271/37 for the LDL. So why is this happening? Well, one theory behind this is, weight loss can actually facilitate increased intestinal absorption of cholesterol. So it's a possibility that it was because of that weight loss that came, they're becoming better at absorbing the cholesterol in their diet, and their diet is a higher proportion of fat, thus leading to more cholesterol as well. This workup, the secondary evaluation that can be pursued, this is from Obesity Medical Association's Physical Activity and Diet Position Statement 2022. They recommend confirming presence of the dyslipidemia with a repeat, checking for secondary causes, diabetes, hypothyroid, nephrotic syndrome, liver disease, check for medications associated with this, beta blockers, glucocorticoids, amio, cyclosporine, anabolic steroids, protease inhibitors, and certain diuretics, and then consider evaluating for diet-sensitive genetic dyslipidemias, such as cytosterolemia. Strategies you can employ when patients on a ketogenic diet develop dyslipidemia, you can try to replace this dietary saturated fat with polyunsaturated fat or monounsaturated fats. You can reduce the dietary cholesterol. You can consider trial of Zetia if you think it's due to they're a hyperabsorber of intestinal cholesterol. You can consider other cholesterol medications, such as statins, which worked really great in some of these patients in this case series. And then ultimately, you might have to trial off the ketogenic diet or stop it completely if dyslipidemia doesn't prevent. This next, I want to talk a little bit about Mediterranean diet. I think this is a very popular diet that we know about when it comes to its health benefits. But the original Mediterranean diet is the diet that was described in the 1950s and 60s of the 20th century in the Mediterranean basin. It's a little bit different, I would say, probably than what's necessarily eaten in the Mediterranean now. It's a diet that is high in vegetables, fruits, legumes, whole grains, and nuts and seeds, moderate intake of seafoods, fermented dairy products, poultry, eggs. It's got low intake of red meat in general, ultra-processed foods, saturated fats, and the diet does allow some red wine intake. So I hope this is easily seen, but this is a literature review of what exactly the Mediterranean diet was for research purposes. What were researchers saying was the Mediterranean diet when they were evaluating its efficacy? And in the red box, you can see the average content of these diets together. And the box below that is Australian standard serving size. So you can see the diet has 300 grams of bread, 305 grams of cereal, 35 grams of legumes, and 125 grams of potatoes. When we look where it shines is 375 grams of vegetables. A serving size in Australia is 75, so it's about 5 servings of vegetables per day, as well as 225 grams of fruit, which is about a serving and a half, given a serving size there is 150. We also see when we look over at the far right that olive oil, 45 milliliters, a serving was 10 milliliters, as well as there is some fish, 50 grams, where 100 grams is one serving, and there's some meat, 105 grams, where one serving of meat is 65 to 90 grams. So there's, again, some meat, some fish, but not very high in these when it comes to how much is in a Mediterranean diet. Major pros and cons of this diet. It may reduce ASCVD risk despite higher fat content. It's low in saturated fat. There's some research that shows phenol-rich extra virgin olive oil has shown hepatoprotective effects and has inhibits inflammation and steatosis, and may also contribute to anti-inflammatory, anti-cancer effects. The diet high in fiber, 25 to 35 grams, high in fruit and veg. It may improve insulin-resistant lipid profiles, and it's safe for all ages. Major cons is you might not see as much weight loss as very low-carb diets. I want to next talk about the DASH diet. So the DASH diet initially was introduced in 1997 by the NIH. And its original starting point was actually this trial, which was 1997. So researchers at that time were setting out to try to find a diet that would help curb hypertension. So they took 459 patients who either had high blood pressure or hypertension, were at least 45 years old. The control group ate the standard American diet, and then the second group ate a diet higher in fruits and vegetables. And they note in their paper that it's a diet that's also lower in snacks and sweets and provided high amounts of potassium, magnesium, and fiber. Then the combination diet was a diet that took that fruits and vegetables diet and included low-fat dairy foods as well as reduced saturated fat, total cholesterol, and total fat and cholesterol as well. All of these patients ate about 3 grams of salt in each diet. And you can see pretty quickly when you look at systolic and diastolic blood pressure response to these diets that at the very bottom, that's the combination diet. The middle line is the fruit and vegetable diet. The control diet is at the very top. There's a significant improvement in blood pressure with this type of diet. So the next thing they did actually occurred in 2001, and they were looking to see like, well, we know that when we put patients on a DASH, the combination diet, which is now in 2001 being called the DASH diet, we know that when we place patients on this diet, we're seeing a blood pressure improvement. How does sodium affect that? So they took 412 patients who had hypertension and were on average 48 years old. They split patients into 2 groups. One was eating standard American diet. The other was eating the DASH diet, which is the combination diet from previously. They then had them eat 3 different levels of sodium, 150 millimoles, which is 3,500 milligrams, and that was the average amount of sodium in a diet in America at the time. And then they took 2,300 milligrams, which was the recommended amount of salt intake at that time for a diet, and they took 1,150 milligrams, which was their postulated level of salt intake that would have further blood pressure benefits. And comparing these 3 groups, you can pretty quickly see definitely at any specific sodium level, blood pressure is better for the DASH diet compared to the control diet, but you also see additional benefits as you decrease the amount of salt you consume. So that's kind of the groundwork for which created the DASH diet as you know today, which is a diet high in vegetables, fruits, whole grains, fat-free, low-fat dairy products, fish, poultry, lean meats. And it's a diet that discourages sodium, limited to about 1,500 to 2,300 milligrams per day. It's a diet where the fat is a little limited. It's 27% of total calories. Saturated fat is less than 6%. Cholesterol is typically limited to less than 150 milligrams for a diet of 2,100 calories per day. It's limited red meat, processed meats, and sugar-sweetened food and drink. So main benefits of this diet is, it can reduce ASCVD risk as well as improve blood pressure and dyslipidemia, but it can be challenging to maintain such salt restriction, and it may not be ideal for weight loss. I want to touch briefly on fasting. Fasting, I would say, is something that's more popular today, so I'll talk about it for 2 slides. So there's periodic fasting, limited food intake for 2 consecutive days, followed by a week of normal feeding. There's intermittent fasting, which has 3 common patterns people follow. there's a 5-2 pattern, which is you limit food for 2 days and have 5 days of normal eating. There's a 2-1, where you have 1 day of limited food and 2 days of normal eating. And there's alternating 1 and 1. And there's time restricted eating, which is food intake is limited to a fixed period of time during the day. So major pros and cons of this dietary pattern is that major pros that it decreases decision fatigue. People don't have to really be thinking about what they're eating. They just have to keep in mind, I have to eat during this time frame. On the other hand, there are multiple cons of this way of eating. It doesn't evaluate the quality of the meals. That's a pro and a con. It should be recommended cautiously in people who have eating disorders or psychiatric disorders to begin with. As one prospective study over 5 years showed an increased risk of developing binge eating or bulimic pathology by following fasting of some type. It can increase risk of hypoglycemia in patients with diabetes if medications are adjusted. It's unclear the long-term sustainability of such a way of eating. About 38% of patients in one randomized controlled trial fell out within a year compared to 29% in the caloric restriction group. But that is definitely controversial, as in some studies you don't see that difference. And the prolonged fasting can cause issues such as gout, or can promote things like gout, nephrolithiasis, postural hypertension, cardiac dysrhythmias. This is a graph about the NOVA criteria. So the NOVA criteria is a way that came out of Latin America of grading how processed food is. So when you look at the left, the orange box, that is unprocessed foods, and that's things like chicken, fish, eggs, and then you have processed culinary ingredients, which include things such as butter, salt, sugar. Processed foods are your breads and cheeses. And then ultra-processed foods on the far right are things like sugar-sweetened beverages, like hamburgers from fast food and things like that. So the importance of this is when we look at this trial, which is from 2019 in the NIH. They took 20 patients, and it's a crossover study where they fed them ultra-processed food or unprocessed foods over 14 days and allowed them to kind of eat as they want. And on average, patients who ate the ultra-processed food ate about 500 calories more, resulting in about 2 kilogram weight difference between those two groups that was lost when they transitioned to the unprocessed food. Now, energy density was not well controlled in this experiment, so that could explain some of the caloric differences. But I have to thank Dr. Marcelli, who showed me that there's actually another trial that's coming out in 2025 from this same group of researchers to better understand why is this happening. Like, is it due to the hyperpalatability of these foods? Is it due to the energy density that's in these foods? Or one thing I've thought of before is whether just because the processing itself may affect the amount of calories you're able to pull out of the food as well. Just because we know that there's a thermogenic effect of food, and the processing might make that easier for the body to get more calories from it. When it comes to, well, what diet is actually most helpful for us, this is the same group of researchers that looked at the DASH and the DASH sodium studies. It was in the 2003 to 2005, they began to look at the DASH diet that they created and compare it to the Mediterranean diet. And they found that one major difference is the macronutrient breakdown of these diets. Otherwise, there was a lot of overlap when it came to the foods that they were actually promoting. So they created these 3 separate diets: omni-carb, omni-protein, and omni-unsat is kind of how they're called. And omni-carb is the original DASH diet. It is a diet that is 58% carb, 15% protein, and 27% fat. Then they had an omni-protein group, which was 48% carb, 25% protein, and 27% fat. And the omni-unsat group is 48% carb, 15% protein, and 37% fat. They then, the diets I want to point out had, first of all, low saturated fat. You can see that 6% of the diet was saturated fat for these patients. And 2 things I want to point out before we dive into the outcomes of this study is that the fruits and juices was significantly higher in the carbohydrate group, And we know from more recent data that juicing fruit is not the same as eating a whole fruit. Juices are not as healthy as eating an actual piece of fruit. So that is one consideration when we look at this data, that the juice in fruit, the fruits and juices was higher, and it doesn't really differentiate that in the paper. And then the sweets was also higher, because you can see desserts and sweets, 4.6 in carb versus 2.5 in fat and 1.7 in unsaturated fat. So what did we find from this study? Well, before I go to that, I think this slide is just to kind of illustrate where do these macronutrients play out compared to other popular diets. So on the far left, you have the Ornish diet, which is a fat-restricted diet, and on the far right, you have the Atkins diet, which is a carb-restricted diet, and that primarily it's very similar to the ketogenic diet. You can see as you go across to the left from the Atkins diet, you see the Mediterranean diet is right next to the omni-unsat and omni-protein diets, and the omni-carb diet is much closer to the Ornish diet in its macronutrient breakdown. So, like I was saying, the results of this study. So we can see when we look at systolic and diastolic blood pressure and LDL, that omni-protein and omni-unsat were statistically significantly better in improving systolic and diastolic blood pressure compared to the omni-carb diets. And when we look at the far left, we can see overall the omni-protein was better at reducing LDL than the omni-carb diet. Researchers also calculated risk of cardiovascular disease via the Framingham equation. And we can see when we look at change from baseline is where you get the bulk of the benefit. But you can see just changing from baseline diet to an omni-carb style diet, which is like a DASH style diet, you get a 15% reduction in ASCVD risk, 21% protein, and 19.6% unsat and omni-unsat. And when you compare in between the diets, you can see further decrease when you compare omni-protein to omni-carb, which is about 5.8% and 4.2% in fat. So all of this together really kind of starts suggesting that switching to a more like DASH style diet that's higher in protein, higher unsaturated fat, which is very similar to a Mediterranean diet, is most beneficial for overall health, according to this study at least. When we look at, on the other hand, how does diet respond to weight? I mean, how does weight respond to diet? You know, this is a little bit different than what we just talked about in that the major benefit that you're going to get from dietary changes for patients is mostly related to how well they're able to adhere to that diet. Changing weight over this 12-month period was basically primarily correlated by the adherence to said diet. So two separate goals in that one, if you're just looking for weight loss, a diet that they can adhere to is probably the best goal. On the other hand, a diet for overall health, separate goal, probably closer to omni-protein, omni-unsat diets. This is another study from Gardner in 2018. He looked at 609 patients with a BMI of 28 to 40 without diabetes and tried to evaluate, well, if you change people from a diet they were consuming before to a healthy low-fat or healthy low-carb diet, do you actually see a difference in the weight loss outcome? And the answer is no. There was no weight loss difference when you compare changing people from healthy low-fat, changing people from previous diets to healthy low-fat or healthy low-carb. And the interesting thing is in that method section, they do specifically say there was no specific caloric restriction that was given to these patients. So just switching them to a healthier diet helped with the weight loss as well. So that's something that is helpful to keep in mind when we try to help patients with weight loss too. This is a systematic review of meta-analysis that looks at the effects of protein intake and its effects on satiety. And you can see basically on average, a higher protein diet is favored, meaning that higher protein diets do seem to promote satiety. So that is something that if a patient is able to adhere to it, might help them too, kind of having a little bit more protein in their diet. So all these things together, universal commonalities of all these helpful diets that we have today. So these diets avoid ultra-processed foods. They limit saturated fat and sodium intake, and they limit high cholesterol intake, especially in those with high ASCVD. They limit alcohol, they limit trans fats. On the other hand, they encourage minimally processed foods. They encourage vegetables such as greens, fruits, berries, nuts, seeds, whole grains. They encourage complex over simple carbs. And I typically tell patients to shoot for a carb to fiber ratio less than 10 to 1, because that will help suggest that it's less processed. They typically, they encourage low glycemic index foods over high glycemic index foods. They encourage fiber, and they encourage no sugar added dairy products. So last couple of slides, promoting actual lifestyle changes. So this is a study that looks at the use of pedometers to increase physical activity and improve health. And if we look at the top where it says no step goal, you can see that there is no statistically significant change in the steps that occurred. On the other hand, when you give patients specific step goals, such as 10,000 steps per day or other step goals in general, there is statistically significant change, suggesting that having an actual concrete goal that you can give someone helps them have something to shoot for and promote change. This is from the National Weight Control Registry. In order to enter this registry, you have to have lost about 30 pounds and have at least kept it off at least a year. There are over 10,000 patients in this registry, and they've on average lost about 66 pounds and kept it off about 5.5 years. In this registry, you can see the behavioral changes that these patients are having on average, and there's also studies of these patients as well. So you can see 45% of these participants did it by themselves, while 50% did it with some type of, 55 did it with some type of program. 98% had some type of dietary change. 94% had increased physical activity. 75% weighed themselves at least weekly. 62% less than 10 hours of TV watching per week, and 90% exercise at least an hour per day. And there is one study that showed that of these patients, the ones that were successful in keeping it off at 10 years had a lower portion of fat in their diet. This is a meta-analysis and review that looks at how effective was implementation of DPP interventions in real-world setting. It looked at 28 US-based studies applying the DPP to see how effective were we at actually implementing these. Main things to take away from this is, first of all, consistency is very important in that for every additional session attended, weight loss was increased by 0.26%. Additionally, beyond that, they also point out that in order to mitigate the cost burden that come with this, things we can do is that not every single meeting has to be a medical personnel. Non-medical personnel can also be helpful in motivating patients for their lifestyle changes. Lastly, I just want to finish on a couple tools that can help patients with lifestyle change possibly. One is the top right and the bottom left are calorie tracking apps, MyFitnessPal and Calorie King. The top left is the My Plate from the USDA. Basically, you can enter your diet and it can and it will kind of tell you where you're doing well or some deficits you're having. The last thing on the bottom right, you have Silver Sneakers, which is a program open to patients on Medicare that gives them free gym access to select gyms, as well as has online classes for them to attend for free as well. Those are my references, and thank you for your attention.
Great. Questions, anybody? And I'll open it up to the audience as well. I don't know how well they can hear me, but.
Oh, okay. Yes.
I have to give you a question, right? So, so you said no processed food, high protein. So what about all those protein shakes and protein bars that are everywhere? So are they processed food? Are they good? Are they high protein?
I mean, they are processed foods, but I think there's. I don't think I specifically looked at how protein shakes fit into all this. I typically would not recommend it if people can avoid it, but if they can't, then I think that's a good alternative. I do know that there is data that looks at meal replacements in patients with weight loss, and that is beneficial. But so I think if they're unable to achieve those goals without it, I think that's helpful. But if you can't avoid it, I would lean against it.
I went to a conference about eating behavior, and there was a session about the physical qualities of food and how liquid foods don't cause as much satiety as more solid foods because they're liquid, so they leave your stomach faster and they're digested more easily. And this one expert in this field was saying that protein shakes probably don't affect satiety as much as we think. So if someone has protein shakes in their diet to meet their protein goal, for example, after bariatric surgery, that's good. But it may not be as beneficial as we think in terms of satiety, at least, because when I recommend increasing protein, I will say that's going to help you stay full for longer between meals, and protein shakes are probably not the answer. So I usually say 1 protein shake a day, at least, because again, I also have concerns about the fact that they can be ultra processed, very processed.
I think one other, sorry, go ahead.
I was just gonna say, so that drawer full of protein bars that I have for lunch every day, it's probably not the best. In my office, I'm doing it so I can eat and work at my computer.
No, this is just a thought generation. I have 3 boys in the house with lots of protein, constantly telling them, don't, because they grab the protein shake and protein bar, which is not necessarily always good for you.
I think the protein need that people have is a little difficult to exactly pin down because the RDA's 0.8 grams per kilogram protein intake is based on nitrogen studies, which have their own issues when you measure them, and that exactly how they're calculating the amounts there's been some question about it. So on the other hand, like promoting too much protein, like it's kind of where exactly is that line? So I think it's a little bit difficult to exactly say how much protein should people be consuming. I think some physical, like some exercise physiologists I've read about recommending, but maybe closer to 1.6 kilograms per kilogram for actually how much people need for like strength and muscle growth. I know a lot of teenage boys, and I fell in that category, would eat like a lot of protein and be like, I'm gonna grow a lot of muscle, but I think really you need, like resistance training is probably the more beneficial thing for that.
Just one other comment about diet in practicality, and Lisa can comment. So, after all these years of practice, the diet is a very personal thing. All of this is really good if you start them as a baby. And so many of our patients, they come to us in their 40s and 50s and 60s, dietary patterns are set. After years of dietary advice, I take a little step back because, I have done something all my life, and just because Dr. Kidami said so that you have to eat that way, patients cannot change that. They can do it. So you showed the dietary, so the best diet is the one that you can follow. Every single diet works as long as you do it. People can only do diets for about 3 to 4 months. After that, Lisa is the expert, the hunger comes up and then there's metabolic adaptation. It really goes out of the way. So we have to be very kind towards patients. When you give the diet advice, really they're not you. You have to come from them, their circumstances, where they're growing up and what it is. Because you could think about, going and telling your grandma, eat this way. They cannot eat like that. Or your own parents, try to tell them like how to eat. How many of our parents they cannot change. And I'm 50 now and I cannot change now. I have to go back to what, so you have to think about all of the, this is really good. but I also want as providers to think about the obesity medicine is very, very, very based on kindness and compassion towards the other person. So let's just remember that. And while we are giving dietary advice or exercise advice, come from their, viewpoint. That's all I would add.
So, quick question, Jack. I mean, great talk. So, go ahead, virtual, if somebody had a question.
Hi, can you hear me?
Yep.
Yes.
Hi, great talk. This is Dr. Teves Qualer. I have a question. I was looking at your slides about cheese being as a processed food, not ultra processed, but processed. The interesting thing is that for my patients who have osteoporosis, I recommend like low-fat mozzarella cheese sticks, but in general, they gain weight with some of cheese ones like H cheese, cheddar cheese. So do you have any comments about that? Because that's a healthy snack, I thought, and now I have to think about that one.
I don't think I specifically limit cheese intake in a lot of people, but probably too much of it is also bad just because it'd be higher in saturated fats as well. And we know from all these studies that lower saturated fat diets are very important and helpful. So I think I would curtail it to some degree just because also in a lot of these studies, the dairy that they're consuming is like low fat dairy.
So bottom line, I can still recommend low fat dairy.
The DASH style diet is based on it has like the combination diet had low fat dairy as that was one of the key differences between that and the vegetable fruit version of it.
Jack? Thank you.
Hi, Jack. This is Joe Shaker.
Yes.
Talk, and I have a question. So you didn't include androgen treatment and growth hormone treatment as a lifestyle, and I'm not saying it should be, but I think many of our patients would. I have seen identical. You showed some slides with the decreased muscle fat. And I have seen essentially the same thing in lectures about growth hormone treatment of not only humans, but animals that are used like pork. It's a leaner pork because they give the pig growth hormone. So maybe we should be getting growth hormone.
I don't have a comment on that.
I think exercise is cheaper than that $1,000 a month in growth hormone.
Well, but it's a lot easier to give yourself a shot once a week. Now we have long-acting growth hormone. It's a lot easier to give it a shot. You could say the same thing about the weight loss drugs that are shot once a week. I'm not saying we should, Ty. I'm saying that we should be open to the possibility that older people with excess body fat, maybe they would benefit by a little extra growth hormone because their IGF-1 has gone down. I don't know who in the group can help me with this question.
Very thought provocative, Joe. But all those experiments done by Dr. Shetty and Dr. Rudman, there were too many complications for the growth hormone therapy.
Well, that's a good point.
Let the way, right, back in whenever, 80s or 90s,
yes,
they gave a bunch of people growth hormone and it fell out. When I started fellowship, I think even Ty remembers, like a bunch of old people used to be on growth hormone and it fell out because the complications are way too many. Yes, short term maybe, but not for elderly, I think. The glucose metabolism and all of the other things.
Yeah, that's a good point, I think. Those studies that study was published in the New England Journal, I think.
Yes. And his garden is still there in the VA. Dr. Rudman. Yeah. He did the studies on growth hormone, gave a bunch of old veterans growth hormone. And, he was a geriatrician. There's a garden, little garden when you go up to the stairs. That's Rutman Garden in the VA. Unless they took it out, but they built a garden for them. Little.
So one, oh,
I have two questions, one serious, one not serious. Great talk. One is, what did they put on those banners that got people to go up the stairs versus the
I
escalators?
think it was a black and white thing I read, but then
Okay.
it was like
Shame on you.
exercise.
Shame
Yeah,
on
like,
you.
Right, no, that's
stairs, not escalator. I was like, yeah, it was a black and white. Like, it was
it's
probably more
escalator
colorful.
out of order.
Yeah, out of order. So did it actually say, I'm just curious, did it actually say it in there? Or did they show
No,
pictures?
it was things like pick stairs, not escalator. But I don't
Okay.
remember exactly. I don't think it was like escalator doesn't work.
Here's an orange sign
Out of order, big orange cones. Yeah, no. Can you go back to your slides on the GLP-1 where they were looking at liraglutide with the exercise? I thought that was fast because this is a hot topic right now with the GLP-1s and the loss of muscle mass. And I think this is actually instructive. I think this helps. So I wanted to look at the lines again. So gray is placebo, blue is liraglutide only, green is exercise.
Only, yep, and then red is
And the
exercise
red-
plus liraglutide. Yeah.
And the right graph you're looking at is
Lean
change
tissue.
in lean mass.
Yeah, lean tissue, and the left is the percent body fat change.
So there's 0% change with liraglutide.
Right. But I think when you look at the red line on the right, you see the liraglutide plus exercise.
Yeah, they actually gain, on average, they actually gain some lean tissue.
Yeah.
During the treatment phase.
And I mean, I think that's important, right? We hang our hats so much on these. You're going to lose a ton of weight with these new medications, right? I mean, particularly the ones obviously that are much more potent than liraglutide. But I know and especially I've been approached by a number of primary care folks asking about sort of our older population and using these drugs and muscle mass and risk of falls. And certainly I know, our osteoporosis patients, this comes up. But I think this just highlights a little bit the importance of, it's not just these medications for weight loss. Some amount of exercise, as well as diet, obviously plays a huge role in this. It's not just that the drugs are going to cause them to lose muscle mass. It's the whole picture.
Yeah.
I just think that was interesting. I haven't seen this, so I think that's interesting.
All right.
So I just want to also comment on there is a big focus on the lifestyle of individuals or maybe their families, but I think it's even more bigger than that. Like lifestyle of the whole population or the whole country is a major thing, and there's been a lot of studies, especially in Denmark. They did a lot of studies on putting more taxes in food that have above certain count or something, salt or sugar, and that had a major actually impact on the population as a whole. Even simple interventions like putting how much carbs or how much or like this is good versus this is not good in even low income settings like Nicaragua. This has had a huge impact in cutting the childhood obesity in such countries. So I think there is a big focus in individual like medications, the exercise, and so on, but it should be in a larger scale than that.
I think there are a
Can you
lot of.
repeat that?
Abu Bakr, I think that's a really important comment. I've been saying for years that because of studies that show even children will choose more of a healthier thing over one candy bar if you kind of fix, and I'm using the word price loosely. But we really need to do, but we don't have the guts and as a country and to do it is to have taxes and negative taxes based on the health of a product. A McDonald's triple stacker ought to cost $50 and a pound of broccoli ought to be free. And you can adjust those things to be budget neutral and really encourage people to eat and learn how to make things that are better for us. But that takes guts and it takes people willing to do things for the better of the whole rather than corporate greed.
I'll play Jeopardy. I think I can guess the question.
All right. As we're over time here, I'm gonna say, great job, Jack. Thank you for your talk. And everybody have a great rest of your week.
It's funny though, because we have done that for smoking.
Yeah, I was just smoking.
Yeah,
Did
I
it
know.
work with smoking?
Huh?
Did it work with smoking?
You know, one of the lowest states that has the lowest tax on cigarettes?
Huh.
Yeah, it's
Indiana.
fine.
One of the
They have the
highest
highest
smoking
smoking.
rates in the country.
So I just leave it, right?
Yeah.
They have a much higher lung cancer rate.